What a momentous day.
It is.
Welcome to the first episode of Sick Society.
It's very exciting to be here finally.
Yeah, taking a bit of going. So what's Sick Society all about then, Alexis?
Well, it's about how everything around us, the world around us, all the weird and wonderful things that we live in, impact on health.
And who are you?
And who am I? And I am Dr. Alexis Paton. I am the director of the Center for Health and Society at Aston University, where I'm also a senior lecturer in the medical school there.
And how long have you been doing that?
Well, I've been doing that for 5 years, but I have spent the last 15 years studying how people make decisions about their health.
And I don't want to be judgmental, but you don't sound like you're from London.
No. I am Canadian by background, from Toronto, and properly from Toronto.
Which I think is good, because I think we are going to try and talk about issues that are global rather than just local. Although I also think many of the things we talk about are very, very relevant to us locally. So I better say who I am, haven't I? So I'm Andrew Goddard, known to all my friends and some of my enemies as Bod, B-O-D, which I've been called since I was a little kid. I am a consultant in the NHS. I'm a gastroenterologist, so stomachs and bottoms and the tubing in between. And I work at the Royal Derby Hospital in Derby, which is smack bang in the middle of England. I think the reason that I have an interest in sort of the wider determinants of health is because I've had a fairly long medico-political career doing various things, but specifically I've worked a lot with the Royal College of Physicians and it's a dubious pleasure, but I was president between 2018 and 2022, which was the time of the pandemic, when a lot of the issues that we're going to discuss came to the fore. And I think for the first time, people really began to understand that there was a lot more to health than just what they see in a GP surgery. So this is our first episode, Alexis. We are going to talk about sort of the impact on health. What's health?
Oh, that is the question, isn't it? I think what's really interesting when we ask that question, what is health, is that you and I are going to have different answers. If we vox pop the people walking past the building where we're recording right now, they'd all have different answers about what health is as well. And so really, in a way, health is in the eye of the beholder. You know, what does health mean to you? Because for some people, it'll be about an absence of a disease. So they don't have anything in particular, so they're able to carry on with their lives. So they consider that to be healthy. There'll be other people who think, well, health is all about green shakes and being in the best shape of your life and hitting the gym 6 times a week. I don't think you and I are in that particular category. And then there'll be everything in between. There'll be people living with chronic illness where, you know, what is health is a question they ask themselves every single day.
It's clearly something that people are bothered about on a big scale, because it seems to top sort of the issues of interest whenever an election comes around. Although I think immigration of late has become a bigger topic. Yet most people don't, I think about their own health until something goes wrong. All the things I do to maintain and being healthy, I've really got into the habit of doing. But I got into the habit of doing them because firstly, when I was younger, I was, a bit overweight. But also I enjoyed doing physical activity, and I found that was something that gave me a buzz. And it wasn't until I had major health problems that I thought more widely about things like blood pressure. I was lucky when it came to smoking. Both my parents smoked, and we used to come down to the lounge of an evening, my brother and I, into this fog of smoke, which was truly horrible. So that really put me off smoking from the very outset. But with the patients I see in clinic, everybody's just so busy living their lives, they don't really have much of a chance to think about some of the other bits and bobs that will affect them from the point of view of health. So I'm looking forward over the next sort of 8 episodes to exploring those more subtle things that we haven't really thought in depth about. But then what can we do in our own lives? What can we do to influence, to improve the health of others?
Well, I mean, what's really interesting, to bring up the smoking example, is that, of course, there was a time when we thought smoking was a healthy thing to do, right? So they're right up until about the 50s.
Well, in the army, you had an army ration.
You had an army ration. But, it was even to the point where you'd think, oh, well, I'll have a cigarette to clear my lungs. So it shows you how these things kind of come and go in terms of what health means and how transient that is. and how what can be healthy for one generation can change to be not healthy for another.
Yeah, and so in some ways, society sets the rules, doesn't it?
Oh, yeah.
To what's acceptable or what's unacceptable. And smoking would be a prime example of going into a pub 30 years ago. You would expect everybody to be smoking, and that was no big deal. And you'd come home and your clothes would be stinky of smoke. But now the thought of somebody lighting up in a pub is just completely alien.
Oh, yeah.
Well, certainly in the UK. But all the things that people have tried to do to get people to stop smoking have all had varying levels of success. One of the things we're going to, I think, talk about repeatedly is the nanny state, and what does government policy do to change people's behaviours when it comes to their health. And I think that's going to become a bigger thing over the next few years as we swing between potentially, a left-wing government in the UK at the moment to perhaps a very right-wing government coming up. And the whole idea of libertarianism, I can't say it very easily. And that was a big thing in the pandemic.
I mean, so one of the really interesting things about the pandemic is that two things kind of came to the fore. The first is, of course, we realized that the impact of the world around us was really quite stark and had a stronger impact than I think anyone realized, right? And this was because it wasn't just about whether you had COVID or not. It was about the regulations that we had in place. It was about the changes that we made and how that impacted other people's health as well, right? So some people were better able to get through the pandemic more healthily than others. And that was simply down to where they lived or what they did for work. And in some cases, what gender they were, what background they came from. That all impacted where they were coming from. But then equally, of course, with the pandemic came restrictions on what we're allowed to do. And we don't do very well as humans when we get handed restrictions down from on high, right? We don't like that. We like a sense of free will in what we do. And so when we're told not to do something, there's a little bit of pushback. There's a little bit of, and I think that that's where we see some of that libertarianism that you're talking about rising in healthcare. This idea that my health is my business and your health is your business, and never the twain shall meet, right? That it shouldn't matter what you're doing. Health shouldn't impact on what I'm doing for my health. But of course, that's a fallacy, regardless of where you live, because health is a population thing as well. So how healthy a community is, or how healthy a country or a city is just as important to how healthy an individual is. And we know that when a country is unhealthy or sick, that it does poorly across all the board, right? It does badly in economics. It doesn't thrive. The population doesn't thrive. So we can't pretend like we're just islands unto ourselves, because that's just simply not how it works in the real world.
Yeah, I think that sort of the hard end of that bit is A&E on a Saturday night when, you might have lived your life really healthily and not done anything and not even looked at a cigarette or an alcoholic drink. I had a body mass index that's well within the normal range, and suddenly you come down with a chest infection that you've caught off your grandchild, and you're sitting in A&E amongst a sea of people who haven't looked after their health as well, perhaps, and a few drunk people lying around.
Probably more than a few.
The thing is, if we allow the health of our society to get so bad that it swamps our health service such that nobody can use it effectively or efficiently, it impacts on everybody. But again, when it comes to thinking about taxation as a way to pay for improvements in public health or your health service, I don't think people ever think about that, but they certainly have very strong opinions about it if they're in that situation. And I've had to have those conversations many times on the ward where people just don't understand why things aren't happening quickly, or why all the beds are full, or why there's a waiting time to get your CT scan. And health services in the UK and across the world are not overwhelmed. That was another thing that was sort of a word that was bandied around during the pandemic, wasn't it? But they are under severe pressure and they're only going to get busier. But our problem, I think, one of our problems within the health service is we've got lots of stuff to do. We've got lots of technology. We've got lots of treatments. When I was a medical student 40 years ago, the management of a heart attack was aspirin and bed rest for 6 weeks.
That's changed.
That's changed a bit. If you had a stroke, that was it. You'd had a stroke and then you would have to be rehabilitated after that. And cancer, the treatments we have now for cancer that make what was previously seen incurable disease curable, is just quite remarkable. The problem with that is it all costs money.
Yeah.
That's when the politicians have to get involved, because they have to think about where to use their money. And it seems to me that public health always is at the bottom of the pile when it comes to funding, because it's not sexy. We're not talking about the management of cancer. But then people talk about a national sickness service rather than a health service. And I think that's what we have.
Yeah, there's something there about how the message of you kind of have to speculate to accumulate with health in regards to prevention and public health hasn't really filtered through, has it?
No.
I mean, to a policy level, I think the people who work in it all the time know exactly what that means, but
The length of time it takes for you to make a meaningful change is measured in decades when it comes to public health.
yeah.
Whereas governments, well, are measured in periods of 4 years, or for some of our most recent prime ministers, periods of 4 weeks. I think it's really hard, because it's the hard stuff to do. If you've got an amount of money to spend and you've got queues outside your A&E, or you've got people who are waiting a long time to get cancer treatment, in your head, you're going to deal with the urgent before you deal with the necessary.
Well, and when you think about what health has been over time as well, it kind of makes you wonder what the alternatives are. So if we look back in time to what health meant and what healthcare was, then it very much was a libertarian idea. So you took care of you. If you had money, you paid for that healthcare, which was, let's be clear, really dubious. So remember that things like a medical degree back in, 1400s would have involved more astrology and philosophy than any kind of anatomy or anything like that. And then, of course, there was the added bit into it that if you were in Britain, and which is a predominantly Christian country at the time, that ill health was viewed as some sort of punishment from God. So that's one side of the coin, right? So if you can pay for something, then fine, go ahead. But otherwise, you've brought this on yourself. So too bad. But then we don't want to be in a situation where we sink an entire system because we haven't managed to provide pathways for a population to be healthier than they currently are.
Yeah. And I sort of have had a lot to deal with people who really understand inequalities in health and the driving factors behind that. And as somebody who would describe themselves as fairly middle class, I've worked as an NHS consultant, a reasonable salary, live in a nice leafy part of the Midlands. A lot of the things that worry me are not the things that worry large parts of our population. I don't really worry about putting a roof over my head, where the next meal is going to come from, can I afford the heating bill? But one of my ways of thinking is that people who can afford it should help support those who can't afford it. And it's trying to get that balance right and people engage with that. I thought when you started talking about the history of health, I was about to duck my head in shame, because I think doctors historically not come across very well when it comes to health. Yes, we've tended to try and use that as an opportunity for self-aggrandizement rather than actually improving health.
I mean, it is really interesting when you look at the history of health, right? Because we don't have much of a formalized healthcare system until about the Middle Ages here in Britain. And I'm only going to talk about Britain. I mean, if we look at other civilizations, other communities across the world, they've been doing this a lot longer and a lot better than we have here. But it really is more about being a learned individual, in quotation marks, than knowing much about how to do health. And the kinds of things that we think about as traditionally a doctor or a nurse would do now weren't included in a profession, right? So a midwife was not a profession that you could go to school for. You couldn't be a midwife until the 20th century, effectively. It was trained. And so you were sort of seen as like this wise woman. So that was this sort of community group that you could be part of and be a midwife. And equally, we had barber surgeons who were considered to be kind of rough and ready people who could pull bits out of you and amputate limbs and things like that.
But then again, that was a sort of how barber surgeons sort of came into power, was it the Crimean War? Or anyway, when you needed lots of surgeons on the battlefield and there weren't enough medically qualified surgeons around to do the job, whereas barber surgeons were used to cutting and using implements, and then were very effective for trying to stop people dying from large bits of metal being thrown at them at high velocity.
I mean, when you think about what a medical degree looked like in like 1600s, and then you look at what a medical degree looks like now, and you look at what a barber surgeon was doing in the 1600s. I mean, I'd take my chances with the barber surgeon because they've got hands-on training, right? Like they know what they're doing. Whereas medicine was this really nebulous thing. So it was knowing as much about Aristotle and Plato as it was about the human body. What was known about the human body was pretty limited as well. And I wasn't just being glib when I said you needed to know about astrology. I mean, they used to diagnose and prepare medicines based on star charts of when these things had occurred and then how to cure them. So we had this very different approach to what medicine looked like. And the professionalization of medicine ends up taking several hundred years.
So I think the other thing is that you sort of touched on there is that before medicine became professionalized and before we had a National Health Service, the power was very much with the doctors because they had all the knowledge and, there were accepted ways of doing it. And there was an established societal power dynamic between the population and the medics.
Yeah.
I don't think we have that so much these days. Everybody has lots of information available on Dr. Google, but also people are perhaps rightly mistrustful of the information they might receive from professionals. And is that a good thing or a bad thing? I don't know. I think the test of that's going to be as AI really begins to take off and the amount of advice and information you can get about health exponentially increases. What will be my role in 10 years' time? I think one of my jobs at the moment in clinic is to guide people through the huge amount of information available on the internet. And people will occasionally come in with sheaves of paper, but often they'll say, well, I've read this is what do you think? And that's as important a role as it is for me to diagnose somebody as having a particular type of inflammation of their gut or whatever. It's always changing, and how society and medicine and health interact has constantly changed. I think we're very lucky, as I said earlier, that, we've got lots of things that can improve matters. In the Middle Ages, the diseases ruled the show and there wasn't much that anybody could do once you got an infection because, pre-antibiotics. So if you look at how the UK's health service has sort of changed in your lifetime and in Canada and looking at the States, do you think that the health of the population has got worse because of it, got better because of it?
I mean, that's hard. So for the first time ever in generations, we are not living as long as the generation previous. It's around 30 weeks-ish for men and women. A bit less for women. I think it's 28 weeks. So that's already a shock. So we had been going through this period from the beginning of the 20th century until now where year on year we lived longer.
Yeah.
And now we're not. And so we have to take a step back and figure out why that is. I mean, partially it might be about hitting a kind of apex. So what was happening was that we've been living longer but with more disease. Diseases that would have killed previous generations earlier, we're able to live with those and even die with them and not even die of them, if that makes sense. And so perhaps we've just reached a natural summit of that. And now we're moving down the valley. It's hard to know. But equally, what we do know is that it's not just clinical, right? So what we do know is that if you live in poor circumstances, so you don't have a lot of money, then your health is impacted. If you live in areas where there's poor air quality, then your health is impacted. What you eat impacts on your health. Your ability to move around and exercise and keep yourself healthy, it depends on where you live. So if you live somewhere that isn't safe for you to move around, then you're not going to be out running at night to get yourself healthy. We know that what you do for a job impacts on your health. We know that if you're a man or a woman impacts on your health. How long you went to school impacts on your health. And we know that your ethnicity impacts on your health. So all of these are coming together and possibly creating a perfect storm where we no longer live as long as we did before. That's one problem. But the other thing, having said all that, is that we are living longer than we did before, even though we're on a decline. And what that means is the health service has to care for us for longer, and we're living in poor health for longer. So we take up more time and energy and resources of the health service as a result of that. And that's something that we have not been very good at planning for, I think, across all the systems, the US, Canada, the UK. We haven't really thought ahead too much about what this is going to look like. And so now we've reached a point where groups like baby boomers and some of the larger generations of the past are all starting to get a bit more unhealthy because they're getting a bit older, because they're living longer than they're getting cancers in their old age, things like that. And all of that is putting strain on our healthcare system.
Yeah, and we always talk about, say, people are living longer, but actually, to me, the important thing is living healthily for longer. So, living without disability. If you look at the metric of, those who are living without significant disability, that's been stuck for quite a few years.
Oh, yeah.
And now the overall life expectancy bit has now started to drop as well. And to me, that's more important, because I wouldn't want to be, for the record, I'm 58. I wouldn't want to be 80, but unable to enjoy life, do the things I want to do. So, if I couldn't hear, I couldn't see, I couldn't walk, couldn't get out, I would be pretty miserable. So knowing that does then help me to interact with people who aren't well, and understanding when they can't do the things that they want to do, and, and trying to make their lives easier and better so they have a higher quality of life than quantity of life is important. But therefore, any interventions that we're going to do to our overall health, I think, has to be not just about extending life, but making sure that what life we've got is enjoyable as it could be.
And I think that's where the social world comes in. Because actually, when we look at living with some kind of illness or disability, and we also cross-reference that with how much money someone has, what we see is that the richer you are, the longer you live without any of these things, right? And those people who are at the poorest end of that range, what we can see is that it's about 75% of them live with 3 or more chronic or disability diseases as a result of simply how much money they have and what that means for the resources they have to spend on their health. So what I think is really interesting is that while the problem causes issues and strain on the healthcare system, the solution is not in the healthcare system, if that makes sense. The solution is about tackling things like poverty. It's about tackling things like poor housing, because that's actually what's causing this ill health to begin with. It's not that people who are poor somehow just don't care about their health as much or anything like that. It's because the circumstances that they live in combine from a whole bunch of different areas to make them simply more unhealthy. And they have very little control over that.
Do you think the UK is, sometimes I hear it described as the sick man of Europe or the fat man of Europe? Do you think the UK has a particular problem compared to other countries in Europe?
Oh, that's hard to say. So we spend very little money on our healthcare system comparatively to other healthcare systems. What's interesting about the UK is that we also offer a fully funded free healthcare service to our population.
So you think that's a bad thing then?
No, but I think we have to remember that it's not just comparing health of one nation to another.
Okay.
Because when we look at something like, so France, for example, has even though healthcare is effectively free, quote unquote, there's actually an insurance system that deals with how healthcare is provided. Germany is similar. There's a sort of sickness benefit that everyone pays into, and that's what helps cover the costs of. So whereas the UK is a single provider and a single income source as well. So taxes come in, that's what pays for our healthcare system, and the same government that collects those taxes is what employs and provides the healthcare system.
There is a school of thought that says that because we have effectively a free health service, is that people take it for granted and therefore are less inclined to look after their own health. Whereas, you look at some of the health insurance companies now, they will reduce your premiums if they show that you're being more active and doing more stuff to maintain your health. I hope we don't go down a line where we need that, to access the National Health Service. I think the other thing I think is interesting when it comes to thinking of UK as a country is the impact of the First World War, and the fact that we sent all our healthy young men overseas to fight the war. The men that were left were not healthy and not young, whereas in, say, France and other parts of the country which were suffering under the war, the people who survived were the fittest and the strongest. So the genetic stock within the rest of Europe actually improved as a result of wartime, whereas ours didn't. And that's an interesting theory. I don't know how true that is.
See, I'm not as convinced by that, because one of the reasons why we have our healthcare system that we have now is because of those world wars. And what we realized when we were conscripting men into the army was how unhealthy so many people were the world wars in Britain really showed up the issues around housing and nutrition.
Yeah.
And so that planted a seed that leads us to our NHS, right? So at the end of the Second World War, what they're realizing is we need to rebuild, and we need to not just rebuild, but perhaps we need to build anew. And that's where Beveridge and Bevan are sort of architects of the NHS come in, right? So they commission a report to find out what is the best way for us to actually provide sufficient health care for our population so that they're able to be as healthy as possible. Because they've realized after both wars that that's just not happening. If we leave the British population to their own devices, they're not as healthy as they could be. And so the Beveridge report shows this, right? And he talks about these great evils of things like nutrition and housing and all the things that we still think about now when we think about how society impacts on health. And for him, the focus is, okay, how do we improve all of this so that we provide the best services for a healthier nation?
With the idea that if you have a healthier nation, they're going to cost less, although that's never really ever happened. And the costs have just continually spiraled. So I don't disagree with anything that you've said in that part. It's just, the way that the health service has functioned now, because it doesn't focus on preventing ill health, it focuses, apart from, you could argue vaccination is a good example of something that works really, really well to prevent ill health. But because the health service, as people sort of view the NHS, is very much about your GP and what happens when you become unwell, is it a model that's sustainable moving forward?
No, I think we have to focus on prevention. That's something that we need to get better at. And that's because we know that further down the line, that means that people live longer in better health. And so they're less likely to have those last kind of 20, 25 years effectively living with some kind of ill health, which is sort of how most people end up these days. But at the moment, when we think about prevention, we think in a very narrow way. We think, okay, right, what are the health promotion campaigns that we can do? So what are the vaccinations we can do? What kind of screening can we do for disease? What kind of health education, teaching people about 5 a day, obesity, diabetes, things like, sugar content, things like that. What can we do? But the prevention, I think, has to be wider. We need to be thinking about how do we improve housing stock so that people live in better, warmer, cleaner housing. Just today, there's been a news article in the BBC talking about how moldy houses continue here in the UK, despite the fact that a lovely little boy died of living in moldy housing, AWOB, and we have AWOB's law that's coming out. In fact, we have very limited requirements and limited regulations around keeping people out of damp and moldy housing. Well, that's an obvious health risk that has long-term health implications. And of course, fatal ones for certain people, as we learned with AWOB's death. And then we also need to think about, so how do we prevent people from living in poverty and deprivation? So where I'm based in Birmingham, half of the children in Birmingham live in poverty. Half of the entire child population of Birmingham lives in poverty. That is going to have knock-on effects for their health for their whole lives. That's going to impact how they grow up. It's going to impact all their developmental milestones. It's going to impact what they're able to do with their lives for moving forward. And all of that will make them less healthy than the other half of the kids who aren't living in poverty. So we need to be tackling those things. Sometimes we're too narrow-minded and thinking, okay, what clinically can we do? And we need to be thinking, well, wider, what is it that we can offer to promote health?
It's always difficult when you are in clinic with a patient or you're on the ward seeing a patient who's come in with pneumonia or whatever. You are faced with the acute issue of the moment that you need to solve. And I will know that some of the people in clinic, their severe irritable bowel syndrome is made worse by a lot of those factors that you've mentioned. But what I have as a doctor in my armory to do anything about that, very, very little. Mm-hmm. So you end up with a sort of a transactional thing whereby you are just trying to fix the problem, and I can offer medicines and I can offer advice and support, and hopefully that's helpful. but the underlying causes I have very, very little control over. I'm interested in that because, like you, I want a healthier population. But I don't think we as doctors spend a lot of time thinking about these bigger issues. But part of that is a feeling of helplessness. There's only so much that we can do. I've voted for lots of people in elections that didn't come to power, so that's good because I can then blame the government at the time for whatever problem. But we live in a democracy. I think the other thing you sort of were saying there, which I agree with, is that the people who will, the time, the motivation, and the things to support them to make major changes in their life can do that. But actually, those that need it most often don't. They are living from hand to mouth. They are living under circumstances that don't give them any freedom to I'd go and buy 5 a day. Buying fresh fruit and vegetables in our country is really expensive. It's much cheaper to go to Iceland and get some frozen food, or just sometimes even cheaper just to go to the chippy, get a bag of chips. And how have we as a society allowed that situation to arise? Because everybody's got to have a right to have their own choice and their own freedom.
But then it's policy decisions, right? Because we allow foods to cost what they cost. We decide that we're not going to insist that healthy food is perhaps kept at a low enough cost that everyone can
Or do we
afford
decide, or do the big companies and the food and the lobbyists decide?
Well, probably the big companies and lobbyists
surely
decide.
We can have a good episode talking about the power of big pharma, the power of
No,
big companies.
and let's not forget that there are what we call the commercial determinants of health, right? Which is how all of these companies and capitalism impact on our health. And I think any conversation you and I are having about this is always overcast or shadowed by the commercial determinants of health, right?
Yeah.
Because it comes back to everything. It comes back to private landlords. It comes back to, as you said, costs of food. It comes back to costs of fuel, everything that it impacts on health.
I read yesterday that 50% of the world's population have less than 1% of the world's wealth.
That makes sense.
And 1%, the richest 1% have, whatever the corollary of that is.
The instinct is to be a bit cynical about it, but it matters, right? Like it matters because the way that we've decided that we run our world and commerce has a direct impact on health. And I'm not saying that we should go back to some other time. I mean, we weren't any healthier in the medieval period, for example, probably even worse off, but we are prioritizing certain things over others that make us more unhealthy. And when you think about the WHO definition of health, to come back to where we started about what is health, and I think it's really telling that in 1948, the WHO come up with this definition of health that they've never changed since, which is that it's a complete physical, psychological, and social well-being. There's a holistic understanding of what health is for them. But we have not been very good at taking that idea of what health is and making it a priority across all those areas.
Yeah, completely agree. And particularly when it comes to mental health is always sort of perceived as sort of a lesser thing than physical health, when the two are very interchangeable and have equally devastating effects on our lives, and you need to pay equal attention to both. It's slightly interesting when it comes to talk about policy and health. What are the things that make policy change on a big scale? So let's take the Clean Air Act in the 1950s.
Yeah.
Now that came around because of the large smogs that killed. What did the London smog killed? 3,000 people or something. That literally they could not breathe because the air quality was so awful. And then the government realised they had to do something and came up with the Clean Air Act. And there was a big shift in how we did industry, how we powered and heated our homes, because government of the day realised that having 3,000 people dying because they couldn't breathe in London was not a very good thing to get re-elected. Sadly, I think it takes awful events like that to shift policy changes on this. Otherwise, people just tinker around the edges because it's not seen as a vote winner. But and I don't want to sound like I'm a BMA basher, because I am a member of the BMA. I think it's important that you are a member of a union. You never know what your employer might do to you one day. But during the pandemic, we had this tricky thing of vaccination. So the first thing to say is that vaccination was our only way out of the pandemic, as they said. And we were amazed that the mRNA vaccines were so effective. We were not expecting this. So it was I think we were really, really fortunate that the technology came up with the right result, despite what RFK, talking about Americans and health, might say. But because we had a shortage, we were then faced with a difficult choice in the December of 2020, which I was actively involved with and has rather scarred me. So at that time, we were giving 2 doses of the vaccine 3 weeks apart. And that was based on the trials that had been done, and they'd been done at 3 weeks, I think, just to allow the trials to happen quickly. I mean, normally, if you're going to give a booster dose of a vaccine, you don't do it at 3 weeks, you do it at 2 months or a bit longer, because you're going to get a better immunological response. And we'd also got good evidence that one single dose was pretty protective. The other thing we knew at that time was the people who were most likely to die or come to severe harm from COVID were those who were old, over the age of 75, and had significant health issues. So when we had to decide how to manage this, how to ration effectively this amount of vaccine, the decision was made by the Department of Health, which I think was the right one, was to delay the second dose to 12 weeks. So as I say, that then allows you to use more first doses in the most at-risk population and probably gives you a better immunological response. And at the time, the BMA said that was exactly the wrong thing to do for doctors, that doctors had to have their second doses. And I can remember some of my colleagues had just got in with their second dose, and I was one of those people who was being told, okay, your dose is going to be wait till week 12. But because I was seeing patients in clinic who were over 75, who were on immunosuppressants, that was exactly the right thing to do. They should be getting a first dose of vaccine before I got a second dose. That was completely the right thing. Yet the BMA were saying, and were publicly, and I had people, because I was president of the College of Physicians at the time, I had people resign their fellowship over this position that we'd taken. But how could I sit there as someone who said I wanted to improve the health of people and look after the most vulnerable in our society and take a second dose that was going to have a small additional protective effect for me as a young, fit person? Anyway, so we now know that action of delaying it 12 weeks probably saved about 15,000 lives in the UK. So entirely the right thing. But the position that my union took at that time, I still look back and I think that really didn't cover the medical profession in glory at all. I understand why people do that, and we're all humans. But sometimes I think as doctors, we forget what we're really there and why we went into medicine in the first place. Okay, rant over.
But this is a really good example of why the world around us impacts on health, right? Because remember, again, the BMA is protecting its membership. Its remit isn't to protect the health of the nation. Its remit is to protect its membership as union body. And these types of policy pushes, the kinds of arguments that you can see from things like the BMA during the pandemic show how something that's not necessarily clinical really impacts on the clinical.
Yeah.
It impacts on health. And, had they won that particular argument, for example, then it's entirely possible those 15,000 lives that we're talking about would not have been saved, right? And that would have had nothing to do with how effective those doses are and how far they are apart, and everything to do with simply the politics and the policy around a particular clinical decision.
That's a really good point. Yeah, the politics is really, really important. It's to how successful a health policy is. Wow. So we've had quite a ranging conversation there. I've learned a lot. It's probably useful for listeners who might want to come back, having listened to this, what our future episodes are going to be about. You've mentioned housing. So we're going to have an episode talking about the role of housing and health with Hannah Fern. I'm looking forward to that one. Climate change, you mentioned once.
Yeah, so we're definitely going to be talking about climate change and sustainable healthcare.
Probably going to have one on the role of fake news.
Yeah, I think we're going to have to.
How that influences things. Food, we've talked about food.
Yeah, we're going to have to talk about food because we know that's another aspect of health.
And I think with housing, we'll talk about the influence of temperature. I think we've talked so much about politics, we're going to have to talk a bit about policy and, maybe we could talk about scandals.
I think we need to talk about when health goes wrong because it's a part of healthcare, actually. So yeah, scandals and patient safety in healthcare when it doesn't do what it promises.
Yeah.
But I think
I try not to promise.
But then I think also one of the things is, we're going to spend most of this podcast talking about what it's like to live healthily or unhealthily. But of course, we don't live forever. And so we will be talking about death and dying as well, because that is a natural part of what life and living is.
The constant thing when we're talking about death and dying, in my time as president, we changed our position as a Royal College from being opposed to assisted dying to being neutral on it. And there were lots of reasons for that. But we were taken to the High Court by a group of people for changing that decision, which in itself was interesting. And within the UK at the moment, we're going through getting a law on assisted dying going through Parliament. It's a very emotive, tricky, complicated area to discuss. But when it comes, you mentioned midwives earlier, it's accepted and normalised that when you come into this world, you will have a dedicated professional in the form of a midwife available to you if you want. You don't have to support that and support the family as they go through that process, mostly the mother, obviously. We don't have anything like that for death, which is like taxation, inevitable.
Yeah, at most we rely mostly on voluntary services, right?
Yeah. Oh, and it's shameful how much in the UK we rely on the hospice movement to provide a lot of our end-of-life care.
And just like everything, I think, so you said taxes and death are inevitable. I think on this podcast, it's inevitable that it all comes back to how the social world around us influences our health. Because these are, again, decisions that have been made at a societal level about how we value death and what that means to die and what services we should have, all the way to policy around what we should fund and what we shouldn't fund.
So when I'm feeling unwell and I don't think the services are working for me, who do I blame? Do I blame the current Prime Minister? Or do I blame Margaret Thatcher? Or do I blame...
Oh, that's tough.
Who do I blame? We'll come back to that. That's not going to be able to answer that one right now.
I think we should probably put a little disclaimer in right now that we will not have the answers to all the problems.
Oh.
We might come up with more problems than answers.
Yes, we'll try and give you fact and a little bit of opinion, rather than opinion and a little bit of fact.
We'll do our best.
This has been a Haunted Mouse production. Cut that out.